think of the incredible duplication. Think of the fact that in the state of New Hampshire, if you type in the word New Hampshire hospitals to your search engine, you get 63 different names. Now, there aren't 63 hospitals in New Hampshire, but when I went through that and ferreted them out, there are over a dozen for a population of 1,000,001. We've got cardiac surgery in a couple of different institutions here in the south of New Hampshire, but there's not enough primary care. We made roads and gas convenient in the 50s, and we all got lazy. We made fast foods convenient in the 80s, and we all got fat. If we could make primary care convenient, we could do a really fine job of straightening the mess out.
I know there was another, yes.
Hi, yes. My name is James Potter, I'm a Hampton resident. I'm a small business owner as well, and I'm suffering every day with the cost of health care. And by the way, the CBO issued a report today saying that the Kennedy plan, which has got a long way to go before it's even finalized, but the Kennedy plan in its current form is going to cost $1.6 trillion more. So I'm a little less confident about our ability to pass a health care plan this year, just because the cost for anything is beyond what we could ever afford, and I'm totally against burdening our kids with any more debt. We can't create a health plan that we have to borrow to pay for. That would be a disaster, in my opinion. The thing I didn't hear much discussion about tonight, and I'd love some practical insight from this wonderful group of people assembled, is the issue of defensive medicine. It seems to me, if you look at what's going on in any healthcare environment, there's a lot of defensive medicine that takes place, and it's almost become epidemic and accepted. And I would love to get some practical insight as to whether that's an overstatement or not, or whether that's a real issue that can be resolved with some relatively simple legislation, so long as the Tory Bar doesn't continue to make major contributions to various politicians. But I'd love some comments on that.
Who would like to address defensive medicine?
All day, every day. Yeah.
Could I have a definition of defensive medicine, please? And could you use it in a sentence?
My friend and colleague who called me this afternoon at 5 o'clock at the end of my day and said, my primary care just did a DRE, and he sent me to the urologist. I had to think, what the hell is a DRE, digital rectal exam? And the primary found a slightly abnormal prostate, and the urologist said, we should biopsy it. And I said, well, what's your PSA? And he said, well, my PSA is normal. I said, well, Dr. Stamey developed the PSA in the 80s. If your PSA is normal and you have a bumpy prostate, you have a bumpy prostate. Why would you go to a biopsy? So he's going to think now long and hard and go back to his urologist. Defensive medicine happens all over the place. One thing I'd like to see is for every single surgical procedure that's elected, and for every surgery and every colonoscopy, a mandatory second opinion as to whether or not that's necessary. You can't do that with certain things. There are emergent things that happen. It's expensive to do that, but it's much more expensive to do the unnecessary colonoscopy. It's much more expensive to do the unnecessary cholecystectomies, the gallbladder surgeries.
So it's a real issue is what you're saying?
It is a real issue, but it's immeasurable.
But
because if I decide I'm going to do your, cholesterol, I don't know that I've done a good job if I check your cholesterol every 3 months or every 6 months or every 9 months. And it's very subject to individual preferences and tastes on the part of the clinician.
I'd like to define defensive medicine, though, because I think what happens in the healthcare system is that there are a lot of tests and procedures that are ordered by physicians because they're afraid if they do not order the latest technology, if they don't send you for a CT, an MRI, a PET scan, and
it's a just in case kind of.
because they're worried about malpractice.
But you don't find it as prevalent with the uninsured because they can't afford to go for those tests.
And they can't afford to sue.
practice defensive.
And by the way, I don't think about malpractice. What I think about is, what if my friend who I talked to at 5 o'clock really does have the prostate?
Okay.
What if he does? And I've just had this 20-minute discussion with him about, I don't think you ought to go to that biopsy. And that was the other discussion he and I had. What would be the consequences if you do have any funding?
We have a general, for the most part, we have a general cultural foundation piece that says more is better.
Yeah.
So why would more not be better in medicine when more is better in pretty much everything else we do?
And we've got it, and we somehow get it paid for, although we don't realize the consequences of the debt.
Jay, here's the point. Why does that colonoscopy have to be done in a hospital setting where you have overhead factors that you have to bring in? Why can't it be done in an ancillary facility apart from the hospital where you have to incorporate the hospital costs into a primary, into a care?
They
You
are
see
now
what I'm
done.
saying?
They are now done much more in ancillary facilities than they are.
But you see, at Exeter
inpatient
Hospital, they're all done in the.
Okay,
Well,
and there's
That's
a,
not in the hospital, though. That's the outpatient, that is a physician's office where colonoscopies are done. That's an outpatient suite.
Is
So in
it?
fact, yes, it is. That's not the inpatient hospital. And that's very important in terms of costs, insurances, and multiple other factors that go into it. I think.
So that's not multiplied by the hospital overhead?
Yes, it is.
and let me,
Not by the
okay, I'd like to,
It's got overhead.
I want to speak in defense of the hospitals on that issue, because there is, part of the cost of hospital overhead comes from the fact that hospitals have to have emergency rooms, operating rooms, and other services operating 24 hours a day, 7 days a week. Whether or not the overhead cost that dribbles down into services that don't have to be performed in an intensive setting like a hospital is certainly a debatable point. But when you start to peel off some of the more profitable services that can be offered on an outpatient basis and create for-profit settings in which those services are delivered, the hospital has less of an ability to shift the, they're shifting the cost, so they have less of an ability to distribute the cost across all services, and the cost for them of maintaining their essential services, has to be borne, and it's no longer possible at times for those hospitals to keep emergency rooms or operating rooms open. So again, it's debatable whether all of that overhead is necessary. But the hospital industry, and I don't want to have Judd take all the heat tonight, does have a legitimate reason for charging some overhead on those kinds of services. And it's the conundrum of where we are, in that there are reasons on both sides of the fence. There are reasons to be defensive in the provision of health care. Number one, you might be wrong sometimes. Number two, there are people who are quick to sue. Number three, health care costs a lot, and I think what we as a population really need to understand is that it is going to require a partnership among the providers of health care, among the consumers of health care, and the folks who are paying for health care to sit down at the table and make sure that everybody's giving some in order to get a better outcome. And I think, Judd hit the nail on the head earlier when he said, is universal coverage, everybody gets what everybody wants, paid for by someone else? I don't think it's